Hello. So this presentation is going to focus on some of the neurological disorders or conditions that you may see when working with the pediatric population. And some of these are going to include head injury, submersion injury, seizure disorders, hydrocephalus, and myelomeningocele. So this part of the presentation is going to focus on a brief overview of a focused neuro exam, assessing level of consciousness, and then a review of head injuries or head trauma. So in assessing pediatric patients, it's important to note that younger children, specifically infants and children under 2, may be a little more difficult to assess their neurological status because they may not be able to respond or follow the directions in order to elicit an appropriate neurologic response. Most of the responses that we look for, especially in infants, are the infant primitive reflexes, looking to see if these are intact. And then once the primitive reflexes diminish, we start looking at meaningful movements. So for example, looking to see if they're meeting expected developmental milestones. And then again, remembering that these milestones develop in a cephalocaudal or a head to toe direction. When completing the neuro exam, it's important to obtain an accurate, objective, and descriptive baseline so that it can be used for comparison if there are any changes and that others that are observing or reviewing the patient's information gain a better understanding of what is that patient's baseline and will recognize if there is a change in status. Like on all of our patients, we will obtain vital signs. These vital signs can give us information regarding the adequacy of circulation, give us clues or information about potential underlying causes of altered levels of altered consciousness. The autonomic activity is changed or disturbed in cases of deep coma or a brainstem lesion. So the skin may give us clues that something may have occurred to cause an alteration in the neuro exam or level of consciousness. So for example, any bite marks, if they have any tics, signs of injury, or even substances that are toxic that may be found on their hands or their clothing. The eyes can give us a lot of information regarding their neuro status. So one thing to assess is their pupil size and the reactivity. So we're looking for pinpoint pupils, maybe a potential poisoning, and dilated pupils may be present after seizure activity. So we're looking to see if they're symmetrical or if it's only on one side. Another thing that you may see done, especially if there is suspected trauma, is having a fundoscopic exam completed. So this may reveal papilledema or pre-retinal hemorrhaging, which is almost always associated with acute trauma and intracranial bleeding. Often, a common cause of this is shaken baby syndrome. So for motor functioning, we're observing for spontaneous activity, we're looking at their gait, response to painful stimuli, as all of this is going to give us clues to the location and potential extent of cerebral dysfunction that's occurring. If posturing is present, this is something that can be evident when cortical control over the motor function is lost in the brain dysfunction. When we're testing reflexes, these tend to be absent when a patient is in a coma, or they may be impaired or absent with severe brain damage. There may be others that persist or are present past when you would expect them to be, such as the Babinski reflex that may indicate potential damage to the brain or spinal cord. And then last, of course, we're going to be evaluating their level of consciousness. Are they alert and arousable? The level of consciousness is the earliest indicator of changes in neurological status, so it's important to pay attention to. It helps us detect if a life-threatening complication such as cerebral edema is occurring. Assessment of level of consciousness includes response to vocal commands, spontaneous behavior, resistance to care, and response to painful stimuli. So note any abnormal movement, changes in muscle tone or strength, and then body position. Parents or caregivers can really help provide us clues if this is the child's baseline or if there really has been a change. And of note, motor activity, reflexes, and vital signs are not parallel to the depth of the comatose state, but the level of consciousness is. So now the Glasgow Coma Scale is often used to assess eye, verbal, and motor responses and really gives us an indication of the person's level of consciousness. A decrease in that GCS or the Glasgow Coma Scale score indicates deterioration. Now the pediatric version of the Glasgow Coma Scale recognizes that expected verbal and motor responses must be related to the child's age or developmental level. So it's adjusted for that. So for children under 2, for the verbal response, it looks for things that the child may be able to do developmentally, so smile or cry. Orientation, so identified by knowing their own name or recognizing their caregivers. So as you can see, there's numeric values assigned to the levels of response in each of the categories. And the lower the score, the deeper the coma. And then you have someone with an unaltered level of consciousness. They're actually going to score highest or have a score of 15 as their total. A score of 8 or below is accepted as a definition of being in a coma. And then the lowest score that a person can receive is a 3, and this indicates a deep coma or death. So you can see basically they can get a score based on like what are their eyes doing, their best motor response, and then the best response to auditory and visual stimulus. And then this just gives you an idea when you're assessing for the pupils, the different sizes, if they're brisk versus sluggish. So here are the 2 images of posturing that you may see. So in image A, this is an example of decorticate or flexion posturing, and this is seen with severe dysfunction of the cerebral cortex or lesions to the corticospinal tracts above the brain stem. So here you see rigid flexion of the arms, flexed elbows, wrists, and fingers, and then you will see feet are kind of extended along with the legs, and they may be internally rotated, and you may find that the patient has fine tremors or stiffness. In image B, this is decerebrate posture or extension posturing, and this is a sign of dysfunction at the level of the midbrain or lesions to the brainstem. With this type of posturing, you see rigid extension, impronation of the arms and legs, flexed wrists and fingers, a clenched jaw, an extended neck, and possibly an arched back. So outcome and recovery of an unconscious or comatose child may depend on the level of nursing care and observational skills. So we're going to have to assess to see if emergency management is indicated, and we really need to look to secure that airway, whether it's going to be through an oral airway or mechanical ventilation, which is the primary concern. So cerebral hypoxia that lasts longer than 4 minutes may cause irreversible brain damage. Other things to consider, their gag and cough reflexes may be minimal, so then there can be a risk of aspiration. Secretions are increased. Other emergency measures may include reducing intracranial pressure if signs are present, and then treating shock. So now here are a list of some diagnostics. This just gives you an idea of the variety of diagnostic exams that can be performed to help evaluate cerebral function. This is not an exhaustive list, but some that you may see. What is performed really will be dependent on how the patient is presenting and the things that they're trying to rule out, or use tests that may give them some clues as to what is or is not going on with the patient. So really, when deciding on diagnostics, often the idea is to think about what information the test or lab will provide, and will this change the management for this patient? This may help in narrowing down which diagnostic test to use. So you may see lab tests such as blood glucose, your blood urea nitrogen or your BUN, and electrolytes, looking at the pH, sodium, potassium, chloride, calcium, and bicarb. You might look at some clotting studies. So again, you probably will see a CBC, maybe some liver function tests, blood cultures. If there is a fever and a toxicology screen, or lead levels may help providers determine the cause of unconsciousness in the child or the decrease in the level of consciousness. You may end up seeing an EEG. This is going to detect spikes or bursts of electrical activity that indicates the potential for seizures. It can also be used to determine brain death. You may see lumbar punctures performed or CT scans, and a CT scan is going to identify congenital abnormalities, hemorrhages, tumors, and inflammatory processes. An MRI is going to provide visualization of morphologic features of target structures. This allows for tissue discrimination, which is unavailable with many other diagnostic techniques. And like I said, I mentioned the lumbar puncture, and this diagnostic is going to measure or can measure spinal fluid pressure. And then it helps obtain cerebral spinal fluid for lab analysis to monitor if maybe there's an infection going on. And now with head injury, the 3 major causes of brain damage in childhood include falls, motor vehicle injuries, bicycle or sports related injuries. Head injuries occur especially in infants and children because the force of intracranial contents cannot be absorbed by the skull and the ligaments that support the head. The head is especially vulnerable to acceleration and deceleration type injuries, and a child's response to an injury is different because of their larger head size in relation to the body. So it most likely will get injured. And then they also have incomplete motor development. So they're at a greater risk for falls. Smaller children or young children are also curious and they're exploring, and they don't quite understand the consequences of their action. Infants especially are often in positions in which they can fall, increasing their chances of developing or having a head injury. So for example, if they're placed on beds and maybe not supervised, they can fall from diaper changers, high chairs, counters, just to name a few of the things or the places that they may be placed. And so with primary head injuries, these are injuries that occur at the time of physical trauma. And these primary head injuries include skull fractures, contusions, intracranial hematomas, and then diffuse injuries. And I'm going to talk about some of these in more detail in the next few slides. Something to consider with most head injuries, or the most common head injury, are concussions. And this is a transient and reversible disturbance of brain function that results from trauma to the head. Confusion and amnesia after head injury are the hallmarks of concussion, but losing consciousness is not an accurate indicator for the presence of concussion. Concussions usually take about 1 to 3 weeks to resolve, and it's really important to rest until symptoms resolve and then resume activities slowly to aid in recovery. So now with head injuries, you may also see contusions and lacerations. Contusions are visible bruising, and these represent petechial hemorrhages or localized bruising at the site of impact or a coup injury. You may also see a counter coup bruising at a site far removed from the point of contact. Such as in more serious accidents, there is always the chance for the possibility of multiple sites of injury. So the occipital, frontal, and temporal lobes are the areas that you most often will see contusions or lacerations. Infants who are shaken or have shaken baby syndrome, you often see contusions, or you may see contusions. If they have shaken baby syndrome, they can have severe neurologic impairment, seizures, retinal hemorrhaging, which is usually bilateral, and intracranial, subarachnoid, or subdural hemorrhages from their injuries sustained from being shaken. Cerebral lacerations is tearing of the tissue either from a penetrating or depressed skull fracture, or when brain tissue is actually torn, with bleeding into and around the tear, which can cause permanent scarring and some degree of disability. Another type of injury that can occur are skull fractures. Because of flexibility, the immature skull can withstand a greater increase in deformities before they fracture. So to produce a skull fracture in an infant, force must be extreme. The types of skull fractures that can occur include skull fractures from a direct blow or injury to the skull and are often associated with intracranial injury. And the types of skull fractures include linear skull fractures, which are a single fracture line that starts at the point of maximum impact but does not cross suture lines. Linear fractures constitute the majority of childhood skull fractures. Then there's your depressed fractures, or those in which the bone is broken locally, usually into several irregular fragments that are pushed inward. Depressed skull fractures may be associated with direct underlying mesenchymal damage and should be suspected when a child's head appears misshapen. Comminuted fractures consist of multiple associated linear fractures, and they usually result from intense impact. These fractures are often a result from repeated blows against an object or ejection from a car at a high rate of speed, or they could suggest child abuse. Then there's your basilar fractures, and these involve the bones at the base of the skull in either the posterior or anterior region. Because of the proximity of the fracture line to structures surrounding the brainstem, a basal skull fracture is a serious head injury. And then open fractures cause communication between the skull and the scalp or the mucosa of the upper respiratory tract. Open fractures increase the risk for central nervous system infection when the fracture creates an opening in the paranasal sinuses or middle ear that causes cerebral spinal fluid leakages. Then there's growing fractures, and these are skull fractures associated with an underlying dura tear that fails to heal properly. So with head injuries and skull fractures, it's important to look for any fluid leaking from the nose or ears, as this may indicate that it's actually cerebral spinal fluid. So some complications of head trauma include hemorrhage, infection, edema, and herniation through the brainstem. And I talked about hemorrhage. So epidural hemorrhage, this is bleeding between the skull and the dura, which is a reminder the dura is the outermost layer of the 3 meninges that surround and protect the brain. Then there's your subdural hemorrhage, which this is bleeding between the dura and the arachnoid membrane, which is the middle layer of the 3 meninges that protect the brain. Then cerebral edema, which is associated with traumatic brain injuries, increased intracranial pressure with herniation. So these are images. So you have image A, which shows an epidural hematoma. And you can see the dura is basically being pulled from the skull and moving on and compressing the brain. So that's the dura here. And if this goes undetected over time, this can lead to herniation and death. Epidural hematomas occur infrequently in infants and children, but they can occur after a low velocity fall. Child abuse often accounts for many epidural hematomas in infants and children, and motor vehicle collisions account for those seen in adolescents. Common symptoms in a child with an epidural hematoma with no neurologic deficits include irritability, headache, and vomiting. And then for infants less than 24 months, you may see scalp swelling, irritability, and lethargy. They may also have seizures or reduced oral intake. These can be detected by CT scan. If the severity is not recognized based on the symptoms, herniation and death can result from this. The Cushing triad, or when you see systemic hypertension, bradycardia, and respiratory depression, this is a late sign of impending brainstem herniation. So now the bottom picture shows a subdural hemorrhage, which again is a bleed between the dura and arachnoid membrane. These types of hematomas are more common than epidural hematomas. Most often they do occur in infancy as a result of birth trauma, falls, or violent shaking. So these would be the bleeds that you can see with shaken baby syndrome. Infants or children with these types of bleeds often present with signs and symptoms of increased intracranial pressure. So some signs and symptoms they display can include irritability, vomiting, increased head circumference, bulging fontanelles in infants, then lethargy, coma, or seizures. After a head trauma, the priority assessment includes, we want to assess our CAB, so circulation, airway, and breathing, right? And or if there really is any bleeding that's occurring. We also want to assess their neurologic and thermoregulatory status. After they've experienced a head trauma, we want to stabilize the neck and spine immediately. And we're going to do this with a jaw thrust, not a chin lift, to really open the airway, because again, we want to protect that spine in case there is an injury. If there are any abrasions, we're going to clean those, apply clean dressings. If there is bleeding, apply pressure and ice to relieve any pain and swelling. We want to keep them NPO until instructed otherwise. Assess pain, but not really give them analgesics or sedatives until we can assess their neurologic status. We're going to check that pupil reaction every 4 hours for at least 48 hours. We want to awake twice during the night to check that level of consciousness. And then really make sure that if they were somebody that was at home and they had a change in status or change in their level of consciousness, that they're really seeking medical attention. Then you may see other diagnostic exams, or I should go back and say, we really do want to make sure we did our assessment, get the detailed history. We want to know what was going on or what happened, to kind of understand how this head trauma had occurred. Went through the things that we should do, looking at the level of consciousness, assessing their vitals, evaluating if shock is present. And the diagnostics you may see are CT scans. They really should be performed quickly, within an hour or less, once there's signs of a cerebral injury are identified, in order to really increase the chances of better outcomes. And now, after a sustained head injury, often the infant or child can be cared for at home if they did not lose consciousness, and after their exam, it's been determined that there is no intracranial injury. But instructions do really need to be provided to look for signs of complications or worsening condition. Caregivers should be checking the child every 2 hours, monitoring for worsening of the condition. Changes in levels of consciousness are usually seen again, or they need to follow up with their primary in 24 to 48 hours post-injury, since epidural hematomas usually show up 24 hours after injury. And then for more severe injuries, they will often be hospitalized for these severe injuries. And then if they've had loss of consciousness for several minutes, or if they've experienced prolonged or continued seizures with their head injury, and nothing administered orally at first until the extent of the injury is further evaluated and they don't display any vomiting. Surgical therapy may be required to evacuate the hematoma. And the outcome of the craniocerebral trauma depends on the extent of injury and complications. It's important to assess frequently. So vital signs, neurologic status, and level of consciousness. Frequently, we may be doing it Q an hour or less, just depends. So this really does vary. It will vary based on the patient, but you can't expect that this often. If we really are concerned, you may be assessing the patients more often. Provide analgesia and sedation. So initially, we may not, or we don't give this in the initial stage because it's really important not to alter the levels of consciousness until the extent of the injury is determined. Afterwards, they may require analgesia for pain and sedation for either surgery or to help prevent further injury or complications of intracranial pressure. So we want to make sure that we are promoting comfort for the patients. We want to perform careful observations and record any changes, such as posturing or changes in the response to stimuli and strength. And then we want to assess for other injuries on their bodies. We want to provide family support and have the caregivers involved in the care. And then rehabilitation may be needed, especially for severe injuries causing permanent brain injury. And then prevention. So as nurses, we really can help provide some education to prevent injuries from occurring again. So for example, securing infants in all chairs and seats, making sure to help them safety-proof the home and prevent falls down the stairs. So these are some things that, as reminders for families that we can do. And then I have this image here. It really demonstrates how a traumatic brain injury can impact daily life, depending on the area that was affected. I wouldn't expect you to know all this, but I think it's important to just take a look at it because it will give you clues as to maybe why some of your patients are displaying some of the signs and symptoms that they are. And then submersion injuries. So another cause of unintentional injury in children include submersion injuries. So submersion injuries is used to encompass immersion in a form of liquid that has caused death or drowning and near drowning, which is survival at least 24 hours after the submersion incident. So this is a major cause of accidental death in children. This most often occurs in children ages 1 to 4 years old. It's important to remember that infants and children can drown in any type of liquid and even in small quantities of water. So even in a bucket or even in a sink of water. Cerebral hypoxia is the major cause of death with submersion events. Within minutes of submersion, lack of oxygen leads to unconsciousness, decreased cardiac output, apnea, and arrest. Recovery will depend on the time and effectiveness of resuscitative efforts. Cerebral cells sustain irreversible damage after only 4 to 6 minutes of submersion. And then you have your heart and lungs really can survive longer, up to 30 minutes. Aspiration of fluid often occurs in most of the submersion incidents, leading to pulmonary edema and atelectasis. So after a submersion injury, children are at risk for hypothermia because of the largeness of their surface area in comparison to their body mass. Also, most people think drowning is loud and really can be easily detected, but it often can be silent and really hard to notice that a child submerged into the water and really is having difficulty emerging. So it's just really important if there is any body of water, especially families that do have pools, really to make sure that there are some safety measures around. But again, accidents still do happen. So just trying to take as much caution as possible. So therapeutic management of a child of a near drowning or that has drowned, we need to complete emergency resuscitative efforts at the scene, so our CPR. Management is going to be based on the degree of cerebral insult. Aspiration pneumonia is a frequent complication of a submersion injury. Often these patients are hospitalized for observation, and prognosis, the best indicator is the length of the time that they were underwater. So a child that was under water 5 minutes with the presence of sinus rhythm, if they had reactive pupils and responsiveness at the scene, have the best outcomes. And then submersions greater than 10 minutes and not responding after 25 minutes of resuscitative efforts typically result in severe neurologic deficits or death. Care depends on conditions of the child. We need to really help parents cope with feelings of guilt. Parental anxiety is related to prognosis. We need to teach prevention of submersion injuries, making sure that there's a close adult around to supervise around any body of water. If there's fences that can be put around the pools, covers, and really teaching survival swimming skills to these young children. or using appropriate flotation devices when in water. So that ends this first part of the presentation.